Thank you. Thank you, Pauline, for that kind introduction. And thank you, Pat, for hosting this inaugural event, and to your terrific team for inviting me to come. It's really a pleasure to spend a couple of days in Halifax and to begin to get to know some of the clinicians and system thinkers and students, trainees who are helping to make healthcare better here. This evening, I want to talk about the promise of Medicare. And I want to share with you 3 big ideas that I think can help us to fulfill that promise. So to begin, I think it's important to define what exactly the promise of Medicare really is. And it may seem obvious that it has something to do with living our values, specifically the value of equity of access to healthcare services. Put simply, Canadians believe that access to healthcare should be based on need rather than ability to pay. But Medicare actually binds us together in more ways than just delivering healthcare services. It strengthens our economy, it improves our social stability, and it gives us an example to point to of what it is that our nation stands for. From coast to coast, as Canadian Doctors for Medicare have articulated, it is seen as the highest expression of Canadians caring for one another. So to me, as I've reflected on this question of what is the promise of Medicare, I have come to the conclusion that it is actually a dual promise: to deliver accessible, high-quality services in an equitable way, and to give us something to be proud of. Which means that when we think about how to improve it, we need to think not only about how to improve access to care or the quality of care or the delivery of healthcare services, which frankly is hard enough. We also have to think about how do you make a social program worthy of that iconic status. So how do we choose which ideas to put forward to help us deliver on that promise? There is only one thing that can help us to resolve the inevitable clash of ideologies that Pat mentioned, and that is evidence. We can't build our system on ideas that sound good or seem to make sense. We have to actually be willing to examine all of the available data here and internationally so that we can separate fact from fiction and failure from success. And when we intervene in healthcare systems, we have to be unafraid to evaluate the interventions that we put in place to see whether they can actually deliver. So to illustrate this concept of bringing evidence to healthcare policy, I want to begin this evening by briefly taking a look at the critical evidence on 3 important dimensions of Medicare: cost, quality, and access. And I'm going to point out a few important realities because I think they frame the conversation around the 3 big ideas I want to share with you tonight. First, cost. We spend a lot of money on healthcare in Canada, and so do all developed nations. Last year, we spent 11.2% of our gross domestic product, or all the wealth that we produce as a nation, on healthcare. And that puts us in line with other OECD nations, but still in the top third. What many of you may not realize, however, is that the proportion of that spending that is public is actually near the bottom of our OECD comparators. For every dollar that we spend in Canada on healthcare, 70 cents is spent publicly, and 30% is spent privately. In France, that number is 77. In Norway, it's 86. In fact, we spend a lot of money on private insurance and out-of-pocket on services that are not covered by Medicare in Canada, such as prescription medications and dental care, and those numbers are increasing over time. A recent study by Statistics Canada found that since 1998, our average out-of-pocket expenditures on healthcare have been rising by 3% per year on top of inflation. But what we spend may not matter that much if we're getting good value for that money. And on many measures of health and healthcare quality, we do reasonably well. I always say to my students, I would give us a solid B. Canadians actually report very high levels of satisfaction with the quality of our healthcare. 71% of us say that we would rate our healthcare system as good or very good. And our healthcare outcomes actually do enforce that perception. We know that the average life expectancy in Canada is 81 years, which is a year ahead of the OECD average. Our infant mortality rates are lower than the average. We rank 4th out of 16 peer countries on mortality due to circulatory diseases like heart attacks and strokes, which are the #1 cause of death in Canada. So, all of this is terrific, but there are obviously areas where quality needs to improve. For example, did you know that in Canada, 1 in every 12 hospitalized patients is readmitted within 30 days of discharge? And 1 in every 10 patients return to the emergency department within a week of leaving the hospital. Too often, sick Canadians cycle in and out of hospital, getting treatment from different groups of care providers who don't communicate with each other and who don't coordinate. There's clearly room for improvement when it comes to quality. But of course, the controversy in Canada, as you well know, isn't really about whether or not Medicare delivers the goods on quality. It's about access. By and large, our system does a terrific job of delivering when people are seriously ill, and most of us are actually prepared to accept some amount of waiting in a system where we know that everyone has access. But the reality is that we still have a lot of work to do to reduce wait times in Canada for non-urgent medical care. Only 51% of Canadians can get an appointment with their primary care provider on the day that they call or the following day. I say this with apologies to my patients who are trying to reach me right now. And that puts us at the bottom of the list of G7 countries. In fact, a 2010 Commonwealth survey ranked us 11 out of 11 when it came to wait times for elective surgery. And unfortunately, in Nova Scotia, the problem is really acute. While the national benchmark, for example, for hip and knee replacements is 6 months, many Nova Scotians are still waiting for 18 months or more for their hip or their knee replacement. So in the areas of cost, quality, and access, the evidence is clear. We have much to be proud of, and there is much work to be done. In scanning the policy environment, I see 3 big ideas out there that would help to truly raise the bar for the health of Canadians in the next decade, and would help us to address these challenges of cost, quality, and access. They're not my ideas, I want to be clear, but they are well formulated, they're based in good evidence, and in my view, they meet the key tests for delivering on the promise of Medicare. They would improve equity of access to health outcomes, and they are worthy of an iconic program. These are big ideas that have the power to excite people about what it means to be Canadian. And tonight, with gratitude to the innovative thinkers who continue to develop new ways to improve our system, I want to dedicate each of these ideas to a Canadian patient, because I think it's important that we remember who we're in this for. So here comes idea number 1. I call it 20 drugs to save a nation. I'm sad to say that we don't need to look south of the border to find healthcare that's inequitable, costly, and inefficient. An honest assessment of our approach to paying for prescription medications in Canada reveals a sorry state of affairs. Look, at the time that Medicare was developed in the 1950s and 60s, and even into the 1980s with the passage of the Canada Health Act, the bulk of health care was delivered by doctors and in hospitals, which meant that a system that mostly focused on paying for physician and hospital services may have made sense. And in fact, most drugs were delivered in hospital or through hospital, and so hospital and medical insurance actually covered a lot of the prescription medications that people needed. But today our systems are rapidly transforming to meet the needs of an aging population that is living longer with chronic disease, and doing so not in hospital, but in the community, which is where we all want to be. And one of the mainstays, as you all know, of treating chronic illness has become prescription medicine. Here in Atlantic Canada, 30% of people are without any sort of drug insurance whatsoever, public or private. Yet Nova Scotia currently has more residents juggling multiple chronic conditions than any other province in the country. So the need for prescription drug coverage is actually highest in precisely the areas of the country where affordable access to prescription medicines is the lowest. This problem is not a universal problem. In fact, Canada is the only country in the developed world that has universal health insurance that doesn't include prescription drugs. The result is that 1 in 10 Canadians either doesn't fill a prescription or doesn't take their medicine as prescribed because they simply can't afford to. So I'm dedicating idea number 1 to a patient of mine, longstanding patient in my practice, who I'll call Ahmed. Ahmed is a taxi driver of South Asian heritage. He lives in downtown Toronto with his wife and 3 truly adorable kids. And he works incredibly long shifts behind the wheel. This, by the way, in spite of his university education and his perfect English. Like so many taxi drivers, and as a result of his genetic heritage and his sedentary job, he has been predisposed to develop his current medical problems of diabetes, high blood pressure, and high cholesterol. Although he and his wife are careful in their spending, he simply cannot afford to support his family and pay for his medically necessary medications, which cost hundreds of dollars a month. So sometimes I just don't see Ahmed for a long period of time. And when that happens, I know it's because he isn't taking his medicine and he doesn't want to disappoint me. I worry, as I know he does, about the complications he may experience in the coming decades, some of which could be devastating, such as heart attacks, strokes, and blindness, devastating, by the way, for the system as well as for him and his family, all because he cannot both afford to feed his family and buy his needed medicine. The most obvious way to fix this problem would be to bring prescription drugs under Medicare, just as we have done with doctors and hospitals. But if we can't summon the political will to cover all prescription medications, at least let's just focus on the ones that give us the biggest bang for our buck. Let's choose 20 drugs, or 50, or 100, whatever number you want, that are used to control common chronic diseases like asthma, diabetes, and high blood pressure. These are the illnesses that are seeing patients cycle in and out of our emergency departments. If we can agree nationally, and I do mean nationally, to go in together on public coverage for these medications, we can cover them for everyone, including Ahmed. And if we did this is something that you may not realize, we would actually end up spending less publicly than we currently do. There are 2 major reasons for this. First, you may not realize that in Canada we pay much higher prices than many other health systems pay for their drugs, in particular generic drugs. If we could negotiate prices like those paid in other developed countries, we could easily cover the cost of 20 drugs to save a nation within our current public budgets. For example, right here in Nova Scotia, the cholesterol-lowering medication simvastatin currently goes for 28 times the cost of the exact same pill in New Zealand. The price for 10 milligrams of the blood pressure medicine Ramipril is 25.3 cents here, compared to a mere 5 cents in the publicly financed Veterans Administration in the United States. That's the United States. If we bargained more effectively, the prices we pay, even for those drugs that we already buy publicly, for example, for all seniors in Nova Scotia, would go down. Second, other systems achieve huge savings by bulk buying their prescription drugs on large scale. Just as we all know it is cheaper to go to buy your toilet paper in those big packages with 40 rolls in it, you pay less per roll than if you go to the pharmacy and buy it 2 rolls at a time. The same is true of drugs. When you buy in bulk, you can get a better price. Between our public and private plans, right now we literally have dozens of purchasers of prescription medicines in Canada, and we would do much better on pricing if we had just one. There is good news here on this front, particularly in Atlantic Canada, actually. Earlier this summer, Atlantic health ministers agreed to start cooperating to lower prices by buying those drugs that they do buy in bulk together. And taxpayers are going to save millions of dollars, and more patients are going to be able to afford those medications, all because of some pretty common sense coordination. And right now, as we speak, health ministers from across the country are meeting in Banff, Alberta, and I can guarantee that this issue of pharmacare will be on the agenda. We all need to make it clear to our elected officials that we want to see it moved to the top of the priority list. Reforming our public insurance to include prescription medicines is something that our public officials can do. But the rest of us have a pretty big role to play in fixing Medicare too. As healthcare providers, administrators, patients, and citizens, we need to roll up our sleeves and get to work on idea number 2, a concept that I am calling doing more with less. Doing more with less is about improving access to healthcare for Canadians who need it by reorganizing the way that services are delivered to people. It isn't a single policy that can be implemented by passing a law. It represents a shift in our culture, in our thinking, and it's mostly a shift away from the presumption that the answer to our challenges in healthcare is always more money, more doctors, more tests, more procedures, an approach that has plagued the healthcare system for long enough. Instead, we need to start taking the resources that are available to us and using them more intelligently. This means, for example, that where wait times are long, we don't necessarily need to immediately hire more surgeons or open more operating rooms. Instead, we should ask two thoughtful questions. First, will everyone on the waiting list for this procedure actually benefit from it? And second, where is the bottleneck causing the wait? Could we organize care better in order to have the flow of patients through the system work more effectively without spending more money? The first question, the question of whether that test or treatment will actually benefit the patient, may sound silly to some of you. You're thinking to yourself, well, of course it's going to benefit the patient, otherwise it wouldn't have been recommended by the doctor. Sadly, that's not always true. To illustrate this principle, I'm going to tell you about a patient I call Sam, who came under the care of a cardiologist colleague of mine. Sam was a perfectly healthy man in his 60s. He didn't smoke, he didn't drink, he didn't take any medications. In fact, he was a world-ranked athlete in a competitive sport. And as part of his compensation package at a fancy firm on Bay Street in downtown Toronto, every year he went for an executive physical at a private clinic. One year, in spite of the fact that he felt perfectly well, he was subjected to an exercise stress test, just in case there might be something going on, and some potential abnormalities were identified. So he was sent for an angiogram, which is an invasive test to see whether there's significant blockage around the vessels that bring blood to the heart. Happily, the angiogram confirmed that Sam did not have heart disease, but not before he suffered a stroke on the table, a known complication of the procedure that occurs in approximately 1 in every 1,000 cases. This healthy athlete will never play his sport again because he's paralyzed on one side of his body as a direct result of a completely unnecessary and inappropriate medical test. Now, I know that some of you guys are thinking, well, but what if they had found something? And wondering if the risks aren't potentially still worth it to pick up that one case of cancer or the undiagnosed heart condition. But that's exactly the point. We need to stop thinking only about benefits and start having a grown-up conversation about harm. Friends, millions of Canadians are harmed every year by inappropriate, wasteful, and harmful tests and prescriptions. Radiologists agree, for example, that 30% of CT scans are unnecessary and don't contribute any useful information to the management of a clinical case. And these are scans that involve radiation. To give you a sense of the impact of that, it's estimated that the excess radiation from CT scans in the United States contributes to 14,000 cancer deaths every single year in the United States. Furthermore, and this is just common sense, eliminating useless and inappropriate CT and MRI scanning would make a huge dent in our wait times for those people who actually need these important diagnostic tests without having to buy any new machines whatsoever. It's for this reason that Canadian physicians are following the lead of our American colleagues and have launched a program called Choosing Wisely Canada. As part of this campaign, medical societies across Canada have acted to create top 5 lists of things that physicians and patients should question. And the Maritime provinces have joined in this campaign, including Doctors Nova Scotia, and they're taking their commitment very seriously. I'm hoping that perhaps our panelists this evening can speak a little bit more about how they hope to see impact from this initiative. Remember, the second question that we want to ask when we try to do more with less is whether the bottleneck causing the wait can be alleviated using creative approaches to get us better value for money. So I'm going to explain what I mean here. When I first started practice a decade ago, if I had a patient who needed a knee replacement, I would literally refer them to the orthopedic surgeon whose name I could remember. And that surgeon kept his wait list, it was usually a him, in the top desk of his, drawer of his secretary's desk. And if he went away on vacation for a month, that wait list just got longer. And I had no idea on any given day whether there might be a new graduate in the office next door whose wait list was 0 weeks while this person's wait list was 6 months long. Since that time, and I'm going to speak a little bit about my own experience in Ontario here, there's been a really concerted effort to reduce wait times for hip and knee replacements, as there has been across Canada. And one of the things that have been used here is called centralized intake and assessment. So today, if I have a person who I believe needs a knee replacement because they have late-stage osteoarthritis of the knee, I will refer that person to a single centralized intake service, and they're usually seen within 2 weeks by an advanced practice nurse and a physiotherapist. These highly trained professionals educate the patient about his or her disease, teach them exercises to improve their preoperative strength, counsel them on the importance of weight loss, and apply an evidence-based checklist to determine whether my patient is actually a candidate for surgery in the first place. If the patient is a candidate for surgery, they're then given a choice to either wait for the surgeon of their choice or see the next available surgeon. Centralized intake programs like this are a key theme that arises across successful projects to reduce wait times in healthcare. I'm going to try to illustrate this point of the next available surgeon. So at 6 o'clock when I'm rushing home from work and I have to get something to feed my starving 5-year-old, I stop at the grocery store and I throw a bunch of stuff in my cart and I make a beeline for the checkout. And then I start to do the line dance. You all know the dance that I'm talking about. You're looking at the different lines, you're trying to figure out which queue is the shortest, which one's moving the fastest, who's got the least items in the basket ahead of you. And if I get it right and I pick the right line, I'm home in 12 minutes. And if I get it wrong and I'm stuck behind the teenager who's counting out the quarters on the table, it's going to take me half an hour. Now, if I make the same stop on my way home at the bank, I get a single lineup, and I'm served immediately by the next available teller. The banks have figured out, this is called applied queuing theory, have figured out the beauty of the single common queue, and the grocery store has not. When you pick up dinner tomorrow, you can see this in action for yourself. By instituting a single common queue, we have dramatically improved the flow of patients through our orthopedic surgery suites, reduced wait times, and increased the appropriateness of those patients who are awaiting surgical consultation. And because groups like the Wait Times Alliance insisted from the start on actually tracking wait times, we've been able to measure our progress and see where the success has been slower. So I hear that in April of this year, Nova Scotia allocated $4 million to address long waits for orthopedic surgery. And I really hope that that's going to help to improve the long waits that I know many people are experiencing here. But I think it is important to remember that the innovations that we need in our system may not be high-tech or sophisticated, and they may not always involve more. They can be as simple as a single phone line where there used to be many, or as obvious as the better use of teams so that surgeons aren't the rate-limiting ingredient in access to care. And if we use evidence to address challenges like wait lists and rigorously evaluate changes we make to see if they're working, we can ensure that big new investments like this are well spent. This brings me to the last big idea, and to a patient in my practice I'm going to call Leslie. Leslie suffers from severe asthma. She takes multiple puffers and has been on and off prednisone, a powerful drug with significant side effects, many times to try to control her symptoms. She's been seen by multiple specialists and has been in and out of the emergency department more times than I can count. Leslie's asthma started when the social housing unit she lives in had a flood. Mold grew in the walls of the building, and Leslie's health began to deteriorate. She took photos of the mold, and she brought them to her landlord. Her doctors, including me, wrote letters of support begging them to find her another unit or another building to move into. It took her and us 2 years to get the system to respond. During that period of time, her physical and mental health deteriorated. She became depressed. Her relationship fell apart. She couldn't hold down a steady job. She was coughing all the time. She was embarrassed on the subway on public transit. She gained weight, and her blood pressure worsened because she couldn't exercise because of her breathing problems. As my colleague Dr. Ryan Miley would say, Leslie isn't sick with asthma. She's sick with poverty. She is sick with a lack of access to appropriate housing, decent food, and basic human dignity that comes along with being able to make the choices we all want to make to stay healthy. The third idea I want to talk about tonight is a proposal that can be explained without even a passing reference to healthcare. Yet acting on it would do more to improve health than any single other policy we could support. Decades of studies have demonstrated that as important as healthcare is, it doesn't play the primary role in determining whether or not people will be ill or well. Social factors, like the ones that led to Leslie's illness, have a much more powerful impact on the most meaningful outcomes. The evidence is clear. Income is the strongest predictor of health. So addressing poverty is one of the most important things we can do to address it. Dr. Gary Block at St. Mike's Hospital often quotes one of his patients who once said to him, "Doc, if you really want to make me better, get me some more money." And that is idea number 3, a basic income to bring all Canadians up to a decent standard of living. Basic income is a well-developed approach to reducing poverty using the tax system. It's actually pretty simple. At the end of the year, you file your tax return, and as you've always done, and if you fall below a certain level, you get topped up to a level sufficient to meet basic needs. It's an alternative to costly and bureaucratic social assistance programs that would virtually eliminate poverty in Canada. As Senator Hugh Segal has pointed out, this is not a radical policy. In 1975, the year I was born, in the province of Ontario, we had a poverty rate amongst seniors of 35%. And famously, the Toronto Star did a series of articles about elderly women who were living on tins of pet food. The Davis government at the time implemented a tax-based seniors' income top-up that then spread across the country and formed the basis of our current old age security program. In 3 years, the poverty rate among seniors went from 35% to 3%. There are very few social policy decisions in our lifetimes that have had this kind of impact. And there's pretty good evidence that a broader population-based basic income policy would actually improve health. In Dauphin, Manitoba in the 1970s, a basic income supplement offered to all the eligible residents in a small town reduced hospitalization, particularly for admissions related to mental illness, interestingly, reduced accidents and injuries. A study in Gary, Indiana, found that families provided with an income top-up saw positive effects on birth weights in newborn babies across the whole community, not just the people who were receiving the supplement. Part of what makes these experiments tick isn't just the money that goes into people's pockets, although of course that does make a difference in being able to put food on the table or pay your electricity bill. Income security also means that even those families that never collect a penny know that if they were to fall on hard times, they wouldn't lose everything. And this has positive health effects across the whole community. In fact, basic income is very much like Medicare or any other insurance policy. We all pay in, we all hope we're not going to have to use it. But if we do, there isn't a humiliating process of having to prove our worthiness in order to have our medical bills covered or put food on the table for our kids. The same principles that led us to establish universal health insurance underpin the basic or guaranteed annual income. It's administratively simple, it is built on the concept of pooling risk across communities, and it's based on a belief that access to some basic things should be automatic, a right of citizenship, rather than an act of charity. Given that the Manitoba experiment was nearly 40 years ago, it's been suggested by many experts that a series of pilots, evaluated of course, should take place across the country to figure out how one might design a program like this for the 21st century in Canada. We could get started tomorrow. Let me close this evening by acknowledging that almost everyone in this audience has strong views about what we should do to improve health. And it's almost certain that some of you are disappointed that I didn't mention the solution you were looking for. There are hundreds of good ideas out there that I haven't mentioned, and most of you, the important part is that most of you believe, as I do, that Medicare is worth the ongoing investment of our collective energy and the creativity of those new ideas. But I do think that the test for whether we focus on a particular solution should be the one that I articulated at the outset, namely that solutions should actually reinforce the value of equity and that they should be worthy of the enormous importance we place on our most cherished social program. And when we set out to design those solutions, we should do so based on the best available evidence, unapologetically devoting time, energy, and yes, money to study the effects of our interventions in healthcare systems and learn whether or not they actually work. So no more tinkering around the edges. 20 drugs to save a nation, doing more with less, and basic income. If we start to do these three things, we will see substantial improvements in the health of Canadians. Canadians like Ahmed, Sam, and Leslie, like you and me. We need to take action that is worthy of Medicare. Let's go get started. We have a promise to keep. Thank you.
Thank you very much for the opportunity to respond, Dr. Martin. I think what I particularly enjoyed about your remarks is that they're really focused on the needs of people. And I think if we could get back to the business we're in and think about that instead of thinking about special interests of different stakeholders, that we would go a long way to making the right decisions about the healthcare system. I really liked your comments about doing more with less. One of my backgrounds is in anthropology and social science, and so I know that we're a culture that is enamored with technology and science, and we think that science can solve all of our problems. And we think that if we can get access to some technology, whether that's an MRI scan or a CT scan or surgery, that is the answer to our issues. But we know that, in fact, some people don't do well with procedures. And I think about knee replacements as one of those examples where the outcomes are more equivocal than they are with a hip replacement. And one of my colleagues, Annette O'Connor at the Ottawa Hospital Research Unit, has spent many years of her career researching decision support tools. And these are available if you want to have a look at them at ohri.ca. There's a whole menu of decision support tools that are designed to help patients clarify their values and have access to risk and benefit information prior to visiting with a surgeon so that they're asking the right questions. And I think we find that if people have a full range of information about the risks and benefits of procedures, often they're in a better position to make a decision about whether this surgical procedure is right for me. And I've heard some people say that if we just did that, we would reduce the wait lists for knee replacements significantly. Because people's expectations for what they're going to get from the knee replacement is often very unrealistic. I heard once about a story about a woman who was anxious to have a knee replacement, and after she had her knee done, she found out that she was no longer able to kneel to pray in church. And that was a significant factor in her satisfaction post-op, that she felt that had she known that she was not going to be able to kneel to pray, she would never have had that surgery. So I think it's one of the key things that I think I'd like us to think about is how do we involve people in these decisions? Not that we're making decisions for people, but we're engaging people in these decisions and giving them the kinds of information that they need to have to make those decisions. I think another key area to think about is that there are low-tech interventions that are very effective. One of the faculty at Dalhousie School of Nursing, Dr. Marcia Campbell-Yeo, does research on the impact of skin-to-skin contact of very, very sick neonates with their mothers and how that promotes growth and development and healing. It's very low tech, it's just a mother, but you just put that baby with the mother. And guess what? The baby does better. I think that it's really important for us to think about that and to think about making good decisions around end-of-life care. That often we think that we're doing the right thing, particularly with the very frail elderly, when we go for interventions. But really all we're doing is prolonging the dying, and we're increasing the suffering. And so again, we need to make very wise decisions about when less is more, or when doing a better job with less. So again, it's involving the public more, focusing on what it is that people really need, and then thinking about making wise decisions in partnership with patients, not making decisions for them. So that's really the comment that I would offer. I think you're definitely on the right track.
No, I agree wholeheartedly. And just to say that I think, you chose the word wise, and I think that is the right word. I think too often when we talk about trying to make the healthcare system more sustainable, people interpret these conversations as rationing exercises, and they're not. That's not what we're talking about. In fact, that's why choosing wisely, I think, has been such an effective vehicle for physicians to start having these conversations. It's because it's actually about better quality. And as you say, once you actually engage patients and the public, and those people are grown-ups, they can have these conversations. People are perfectly capable of understanding risks and harms, and is this actually going to improve my quality of life? People are perfectly capable of having that conversation, but somebody needs to have the conversation with them. And I think that these decision tools and online resources for people can be really useful, and yet I do, and maybe this is my bias as a family doctor, I do think that at the end of the day, there is no replacement for a trusting relationship with a primary care provider as the nidus for the majority of those conversations. Because when you have that conversation with someone in relationship, they are much less likely to misinterpret it as being a cost-cutting measure, and much more likely to experience it as what it is, which is a conversation about quality for you.
Thank you so much, Dr. Martin, for being here. And I guess hearing your comments certainly made me feel hopeful, particularly when you were speaking about each of your patients. Because I guess in many ways, the role that I have is someone who is a collector of stories. And I certainly have heard many similar stories from men and women here in Nova Scotia who've experienced similar issues in access to care and access to medication. But at the same time, I guess I also feel hopeful in listening to your idea about less is more, because in looking at long-term care here in Nova Scotia, I think that we have an example of something that is a small pilot project in the Capital Health District that actually feeds into that extremely well. And it's also not just an issue of anecdotal evidence, but it has, I guess, some scientific evidence to back it up as well. Essentially what happened was in 2005, Dr. Barry Clark looked at all of the long-term care units in Halifax and found that the number of family doctor visits to long-term care centers had dropped by 32%. And he found at the same time there was a corresponding increase to the number of emergency room visits. And as a result of that, people who are in long-term care centers may suffer from cognitive issues or dementia, and unfortunately our emergency rooms are not necessarily built to be a safe and effective place to treat those patients. So what he did was he pulled together a team of care providers and created something that he called Care by Design. And now, at least in Halifax, every long-term care center has a family doctor who has volunteered as part of their normal clinical practice to look after one floor in each long-term care center. So once a week, that family doctor will go and do rounds on that floor. They'll develop a relationship with the nurses and the continuing care assistants, so they have a better understanding of these patients' needs. And there is also now a doctor on call 24/7 for each of those long-term care centers. So if there is an issue, then a nurse or a continuing care assistant can call a doctor and have a doctor come and deal with the illness right there in the room. And as a result, I guess the program has decreased emergency room visits by more than 40%. And it has also become a cost-neutral program when they look at the amount of money that had been spent on ambulance transportation, the time waiting in the emergency room, and I guess, the health outcomes for the patients themselves. Yeah.
You know, I think one of the things that I'm struck by in listening to that story is how many pockets of excellence we have across the country in Canadian healthcare. And, you know, every community has a story like that of a committed individual, you know, whether it's a patient or a provider who took on an issue and made it theirs and actually designed and evaluated a stellar program like that. I think the issue that we face as a nation is, how do you scale that stuff up? Because, you know, amazingly, we seem to have, you know, every community is inventing its own diabetes, you know, approach or whatever it is. And it's not that they're not all great, but surely diabetes can't be that different across every single community that we should require, you know, a total reinvention of the wheel. And I think, you know, this is something that we really struggled with when I sat on the Health Council of Canada, was this question of how do you do spread and scale of innovation, and lots of people in healthcare are thinking about this question. And I don't, you know, there's no easy answer to it, but I do think that we need to somehow unlock that, you know, the power of the pilot project to big system change. And so we probably need to bring some experts, I would say even from other industries, who know more about how you move from the small scale to the large scale, to help us think about how a program like that could be used effectively across the country.
Thank you for your wonderful remarks, and thank you for attending. Just a few comments with regards to access and central referral systems. We've had a central referral system here for cardiac surgery in Nova Scotia for some 40 years, and it certainly has been a model for other centers. We also, because of that system, have a very extensive database on every single patient who undergoes cardiac surgery in this province now for over 20 years. And why is that important? Well, it's important because if you're going to have central referral systems, you have to know what your outcomes are. So you have to guarantee that each and every patient in that system is guaranteed an equivalent outcome. And you can't do that unless you know what your outcomes are. And I've always been amazed that in a publicly funded system with a single payer, we have such a paucity of data. One would think that we are the ideal Framingham study. We have a single payer, we have a captive population, we should be able to tell the world how to do this. Having said that as well, we tend to like to vilify the payer or the government. Years ago, the wait list for cardiac surgery in this province was 6 months. We took our data set, we put it together, and we took it to government. And government listened, and government gave us $30 million, and the wait list for cardiac surgery in this province now is about 3 weeks. So government does listen. They'll listen if you make the case, and they listen if you make a valid case. So my message would be to echo the thoughts here tonight. Central referral systems work, but they only work if you keep adequate data and if you present that data to government in an organized fashion. My second comment is about drugs. I think it is very laudable that we should have a system in Canada that pays for drugs. I also think there's a big piece here that has to be addressed by the profession, and that is the issue of polypharmacy, especially in the elderly. When I started my practice in cardiac surgery, patients went home on an aspirin. Patients now go home on a Sobeys bag full of medications. Now, many of those medications are necessary, and many of them work. But we see patients on 12, 15, 17 medications on a regular basis. A lot of these medications are intended to be prescribed for 6 weeks, and patients are taking them 6 years later. So the profession has to own that piece. There are lots of good initiatives now through the family practice groups in all the provinces, and I think this is an issue, though, that as physicians we really have to own and we really have to work to correct. I mentioned briefly Choosing Wisely. We were one of the first provincial medical associations to recognize the Choosing Wisely program and to endorse it. I think it's a good start. I think the red flag is, however, how it's rolled out. And I think if the public perceives this program as a methodology for rationing tests or rationing healthcare or rationing access, it could stop in its tracks. So I think the way it's rolled out is going to be very important. And we've certainly worked with our partners at the CMA. I see the president-elect of the CMA is in the audience here tonight, Cindy Forbes, who is a family doctor here in Nova Scotia. And I think this will be a success if it's rolled out in a proper manner. And finally, I'd like to make a plea to change the discussion from disease to health. The so-called tsunami that is coming down the pipe of elderly, obese patients with type 2 diabetes and hypertension, there will never be enough money in the system to deal with this unless we, you, the citizens, the taxpayers of this country, develop a philosophy of healthy lifestyles. There's very convincing evidence that a 1 hour walk a day has a positive effect on longevity, decreases blood pressure, decreases your risk of obesity and type 2 diabetes. So at the end of the day, we have a healthcare system which I would not rank as highly as Dr. Martin did. I would give it a C-, not a B+. According to the Commonwealth Fund data that came out within the last year, Canada ranks second last in all developed countries. Only the United States is worse. One measures access and outcomes in healthcare. So we have a lot of work to do. I think this is a start. I think we have to have a very strong federal government presence in healthcare. And my last plea for promoting health would be an endorsement of Doctors Nova Scotia. We have tens of thousands of kids in this province now enrolled in our Kids Run program. Promoting active lifestyles. I know our minister is very committed to promoting healthy lifestyles in our province, and I think that will be the secret to funding Medicare in the long term and not increasing funding for an increasing disease population. Thank you.
First of all, I feel I'm blessed to live in Nova Scotia. The healthcare system saved my life, literally. I work internationally, and I was working in the West Indies, walking a beach, didn't feel too well. Came here, the doctor there told me, go back to Canada. Went to see my family physician, says go to emergency, and within 2 hours I was on the operating table with something very, very serious. It left me paralyzed, but I'm alive. So I'm grateful to the service, and particularly impressed by the care given by the people of the healthcare system. I was so impressed by the nursing care and the mentoring that went on the various wards I was in. I was in hospital for about 6 months. The mentoring of the young nurses and the maturity of those nurses. And Dr. Martin, thank you very much for your presentation. And on your 3 points, I'm sold. You explained it in very simple terms. I can understand it. It was very pragmatic, but also strategic, which is what I liked. On some of your comments regarding the 20 drugs, I'm one of these guys with the Sobeys bags with drugs, and I've been asking my doctors, let's review. And it's very, very costly. Luckily, I can afford it. A lot of people can't. So that's a good move. The other thing is with regards to doing more with less. And I really like your queuing example. Borrowing some practices from the private sector. But in some cases, I think we've gone too far with borrowing from the private sector. I hate to be called a client when I'm in hospital. Like, I'm a patient. In fact, I Googled it, and there's a whole narrative and dialogue going on the internet with regards to that. But I had no choice. I was not a client. I'm a patient of the system. The other point about poverty, I like the way you've integrated that in your presentation, and certainly I've I do most of my work in developing countries where, people are earning maybe $10 a month. And you can certainly tell the effects poverty has on healthcare. And I'll share one story with you. I worked for a while in Bangladesh and lived there as well. And there's one picture that will always strike me. There was a man. This was one of the busiest intersections in the city of Dhaka, a city of over 10 million people. This man had no arms, no legs, just a torso and a head. And he was being helped by his 10-year-old son to roll through the intersection to collect alms. Absolutely no safety net. Now, he was fortunate because of his severe disability. He was able to collect more alms. Luckily, we don't have that here. So we're truly blessed with a tremendous system. Of course, we've got to manage it a little better. And as well, one of the things that I've been thinking about a lot, I'm one of these baby boom bulges that's moving through. I'm 64 years old. And it's like the university environment, where that went through, and then, of course, there was a trickle. What will happen after the bulge has gone through, right? Are we gearing up an enormous system that in time will not have much to feed on? How do we manage that? So I will conclude my remarks on that. Thank you very much.
Thank you very much.